Welcome to this video entitled Nausea and Vomiting. Let's begin with a definition. Nausea is usually defined as the inclination to vomit or as a feeling in the throat or epigastric region alerting an individual that vomiting is imminent. Vomiting is defined as the ejection or expulsion of gastric contents through the mouth, often requiring a forceful event. Next we will discuss the pathophysiology of nausea and vomiting. 1. Specific etiologies associated with nausea and vomiting are presented in Table 27.1. 2. Table 27.2 presents specific cytotoxic agents categorized by their emetogenic potential. Although some agents may have greater emetogenic potential than others, combinations of agents, high doses, clinical settings, psychological conditions, prior treatment experiences, and unusual stimuli to sight, smell, or taste may alter a patient's response to a drug treatment. 3. A variety of other common etiologies have been proposed for the development of nausea and vomiting in cancer patients. These are presented in Table 27.3. 4. The three consecutive phases of emesis include nausea, retching, and vomiting. Nausea, the imminent need to vomit, is associated with gastric stasis. Retching is the labored movement of abdominal and thoracic muscles before vomiting. The final phase of emesis is vomiting, the forceful expulsion of gastric contents due to gastrointestinal retroperistalsis. 5. Vomiting is triggered by afferent impulses to the vomiting center, a nucleus of cells in the medulla. Impulses are received from sensory centers, such as the chemoreceptor trigger zone, abbreviated as CTZ, cerebral cortex, and visceral afferents from the pharynx and gastrointestinal tract. When excited, afferent impulses are integrated by the vomiting center, resulting in efferent impulses to the salivation center, respiratory center, and the pharyngeal, gastrointestinal, and abdominal muscles, leading to vomiting. 6. The chemoreceptor trigger zone, located in the area postrema of the fourth ventricle of the brain, is a major chemosensory organ for emesis and is usually associated with chemically induced vomiting. 7. Numerous neurotransmitter receptors are located in the vomiting center, chemoreceptor trigger zone, and gastrointestinal tract. Examples of such receptors include cholinergic and histaminergic, dopaminergic, opiate, serotonin, neurokinin, abbreviated as NK, and benzodiazepine receptors. Theoretically, chemotherapeutic agents, their metabolites, or other emetic compounds trigger the process of emesis through stimulation of one or more of these receptors. Pause the video and carefully scrutinize Table 27.1 summarizing specific etiologies of nausea and vomiting before advancing to the next slide. Next we will discuss the clinical presentation of nausea and vomiting. The clinical presentation of nausea and vomiting is given in Table 27.4. Nausea and vomiting may be classified as either simple or complex. And now let's consider the desired outcome. The overall goal of antiemetic therapy is to prevent or eliminate nausea and vomiting. This should be accomplished without adverse effects or with clinically acceptable adverse effects. We will now look at the treatment of nausea and vomiting. Let's begin with a general approach to treatment. 1. Treatment options for nausea and vomiting include drug and non-drug modalities. The treatment depends on associated medical conditions. 2. For patients with simple complaints, perhaps related to food or beverage consumption, avoidance or moderation of dietary intake may be preferable. 3. Non-pharmacologic interventions are classified as behavioral interventions and include relaxation, biofeedback, self-hypnosis, cognitive distraction, guided imagery, and systematic desensitization. 4. Psychogenic vomiting may benefit from psychological interventions. Pause the video and carefully scrutinize Table 27.2 summarizing the emetogenicity of chemotherapeutic agents before advancing to the next slide. We will now progress to the pharmacologic management of nausea and vomiting. 1. Information concerning commonly available antiemetic preparations is compiled in Table 27.5. 2. For most conditions, a single-agent antiemetic is preferred. However, for those patients not responding to such therapy and those receiving highly emetogenic chemotherapy, multiple agent regimens are usually required. 3. The treatment of simple nausea and vomiting usually requires minimal therapy. Both non-prescription and prescription drugs useful in the treatment of simple nausea and vomiting are usually effective in small, infrequently administered doses. 4. The management of complex nausea and vomiting, for example, in patients who are receiving cytotoxic chemotherapy, may require combination therapy. Pause the video and carefully scrutinize Table 27.3 summarizing non-chemotherapy etiologies of nausea and vomiting in cancer patients before advancing to the next slide. Pause the video and carefully scrutinize Table 27.4 summarizing the presentation of nausea and vomiting before advancing to the next slide. Pause the video and carefully scrutinize Table 27.5 summarizing common antiemetic preparations and adult dosage regimens before advancing to the next slide. Pause the video and carefully scrutinize Table 27.5 summarizing common antiemetic preparations and adult dosage regimens before advancing to the next slide. Next we will consider drug class information. Let's begin with antacids. 1. Single or combination non-prescription antacid products, especially those containing magnesium hydroxide, aluminum hydroxide, and/or calcium carbonate, may provide sufficient relief from simple nausea or vomiting, primarily through gastric acid neutralization. 2. Common antacid dosage regimens for the relief of nausea and vomiting include one or more small doses of single or multiple agent products. Next we will look at histamine 2 receptor antagonists. 1. Histamine 2 antagonists, such as cimetidine, famotidine, nizatidine, and ranitidine, may be used in low doses to manage simple nausea and vomiting associated with heartburn or gastroesophageal reflux. And now we will consider antihistamine anticholinergic drugs. 1. Antiemetic drugs from the antihistaminic anticholinergic category may be appropriate in the treatment of simple symptomatology. 2. Adverse reactions that may be apparent with the use of the antihistaminic anticholinergic agents primarily include drowsiness or confusion, blurred vision, dry mouth, urinary retention, and possibly tachycardia, particularly in elderly patients. We will now discuss the phenothiazines. 1. Phenothiazines are most useful in patients with simple nausea and vomiting. 2. Rectal administration is a reasonable alternative in patients in whom oral or parenteral administration is not feasible. 3. Problems associated with these drugs include troublesome and potentially dangerous side effects, including extrapyramidal reactions, hypersensitivity reactions with possible liver dysfunction, marrow aplasia, and excessive sedation. We will now focus on corticosteroids. Dexamethasone has been used successfully in the management of chemotherapy-induced nausea and vomiting, abbreviated as CINV, and postoperative nausea and vomiting, abbreviated as PONV, either as a single agent or in combination with selective serotonin reuptake inhibitors, abbreviated as SSRIs. For chemotherapy-induced nausea and vomiting, dexamethasone is effective in the prevention of both cisplatin-induced acute emesis and when used alone or in combination for the prevention of delayed nausea and vomiting associated with chemotherapy-induced nausea and vomiting. And now let's look at metoclopramide. 1. Metoclopramide increases lower esophageal sphincter tone, aids gastric emptying, and accelerates transit through the small bowel, possibly through the release of acetylcholine. 2. Metoclopramide is used for its antiemetic properties in patients with diabetic gastroparesis and with dexamethasone for prophylaxis of delayed nausea and vomiting associated with chemotherapy administration. We will now focus on cannabinoids. 1. When compared with conventional antiemetics, oral nabilone and oral dronabinol were slightly more effective than active comparators in patients receiving moderately emetogenic chemotherapy regimens. 2. The efficacy of cannabinoids as compared to selective serotonin reuptake inhibitors for chemotherapy-induced nausea and vomiting has not been studied. They should be considered for the treatment of refractory nausea and vomiting in patients receiving chemotherapy. Let's now discuss substance P, neurokinin 1 receptor antagonists. 1. Substance P is a peptide neurotransmitter in the neurokinin family, whose preferred receptor is the neurokinin 1 receptor. Substance P is believed to be the primary mediator of the delayed phase of chemotherapy-induced nausea and vomiting and one of two mediators of the acute phase of chemotherapy-induced nausea and vomiting. 2. Aprepitant is the first approved member of this class of drugs and is indicated as part of a multiple drug regimen for prophylaxis of nausea and vomiting associated with high-dose cisplatin-based chemotherapy. 3. Numerous potential drug interactions are possible. Clinically significant drug interactions with oral contraceptives, warfarin, and oral dexamethasone have been described. And now let's focus on selective serotonin receptor inhibitors, such as ondansetron, granisetron, dolasetron, and palinosetron. 1. Selective serotonin receptor inhibitors, such as dolasetron, granisetron, ondansetron, and palinosetron, act by blocking presynaptic serotonin receptors on sensory vagal fibers in the gut wall. 2. The most common side effects associated with these agents are constipation, headache, and asthenia. Let's now progress to chemotherapy-induced nausea and vomiting. 1. Nausea and vomiting that occur within 24 hours of chemotherapy administration is defined as acute, whereas when it starts more than 24 hours after chemotherapy administration, it is defined as delayed. The emetogenic potential of the chemotherapeutic agent or regimen, see Table 27.2, is the primary factor to consider when selecting an antiemetic for prophylaxis of chemotherapy-induced nausea and vomiting. 2. Recommendations for antiemetics in patients receiving chemotherapy are presented in Table 27.6, and doses are shown in Table 27.7. Next, we will look at prophylaxis of chemotherapy-induced nausea and vomiting. 1. Patients receiving chemotherapy that is classified as being of high emetic risk should receive a combination antiemetic regimen containing 3 drugs on the day of chemotherapy administration. Day 1, a selective serotonin receptor inhibitor plus dexamethasone plus aprepitant. 2. Patients receiving regimens that are classified as being of moderate emetic risk should receive a combination antiemetic regimen containing a selective serotonin receptor inhibitor plus dexamethasone on day 1. 3. Dexamethasone alone is recommended for prophylaxis prior to regimens of low emetic risk. And now let's switch gears to the treatment of chemotherapy-induced nausea and vomiting. 1. Chlorpromazine, prochlorperazine, promethazine, methylprednisolone, lorazepam, metoclopramide, dexamethasone, or dronabinol may be used for adult patients. Around-the-clock dosing should be considered. The choice of specific agent should be based on patient-specific factors, including potential for adverse drug reactions, and cost. Selective serotonin receptor inhibitors are effective for breakthrough nausea and vomiting, but they are not superior to the less expensive antiemetics above. 2. Aprepitant, dexamethasone, or metoclopramide have demonstrated efficacy in preventing chemotherapy-induced nausea and vomiting, whereas the results with selective serotonin receptor inhibitors are inconsistent. 3. Aprepitant and dexamethasone can be used on the 2 days following administration of high-emetic risk chemotherapy. Pause the video and carefully scrutinize Table 27.6 summarizing recommendations for the use of antiemetics in patients receiving chemotherapy before advancing to the next slide. Pause the video and carefully scrutinize Table 27.7 summarizing dosage recommendations for chemotherapy-induced nausea and vomiting before advancing to the next slide. And now let's focus on postoperative nausea and vomiting. 1. A variety of pharmacologic approaches are available and may be prescribed as single or combination therapy for prophylaxis of postoperative nausea and vomiting. See Table 27.8 for doses of specific agents. 2. Most patients undergoing an operative procedure do not require preoperative prophylactic antiemetic therapy, and universal postoperative nausea and vomiting prophylaxis is not cost-effective. 3. Selective serotonin receptor inhibitors in doses of dolasetron 12.5 mg, granisetron 0.1 mg, ondansetron 1 mg, or troposetron 0.5 mg are recommended in patients who experience postoperative nausea and vomiting, despite prophylactic dexamethasone or when no prophylactic agent was used. Let's now focus on radiation-induced nausea and vomiting. Patients receiving single exposure, high-dose radiation therapy to the upper abdomen, or total or hemibody irradiation, should receive prophylactic antiemetics. Preventive therapy with a selective serotonin receptor inhibitor and dexamethasone is recommended in patients receiving total body irradiation. And now let's look at disorders of balance. 1. Beneficial therapy for patients with nausea and vomiting associated with disorders of balance can reliably be found among the antihistaminic anticholinergic agents. Neither the antihistaminic nor the anticholinergic potency appears to correlate well with the ability of these agents to prevent or treat the nausea and vomiting associated with motion sickness. 2. Scopolamine is commonly used to prevent nausea or vomiting caused by motion. Pause the video and carefully scrutinize Table 27.8 recommended prophylactic doses of antiemetics for postoperative nausea and vomiting before advancing to the next slide. Let's now switch gears to antiemetic use during pregnancy. 1. Initial management of nausea and vomiting of pregnancy often involves dietary changes and/or lifestyle modifications. 2. Pyridoxine, dosed at 10 to 25 mg 1 to 4 times daily, is recommended as first-line therapy. If symptoms persist, addition of a histamine 1 receptor antagonist, such as dimenhydrinate, diphenhydramine, or meclizine, is recommended. And finally, let's look at antiemetic use in children. 1. For children receiving chemotherapy of high or moderate risk, A corticosteroid plus selective serotonin receptor inhibitor should be administered. The best doses or dosing strategy has not been determined. 2. For nausea and vomiting associated with pediatric gastroenteritis, there is greater emphasis on rehydration measures than on pharmacologic intervention. Thank you.